Hi, my name is Tracey King. I'm the myeloma nurse at Royal Prince Alfred here in Sydney. I'm sorry not to be there to present this live, but it's the middle of the night for me, so do excuse the recording. Happy to take questions via email though, and I've left that on the screen for you. I'm just going to take 10 minutes of your time to describe the validation findings from the Steroid Symptom Questionnaire in myeloma. It's a patient-reported outcome measure that I developed to help measure the effects and the impact of steroids for those people with myeloma, and hopefully as a tool in the clinical setting to help us better manage patients on steroids. I'm sure all of you are very well aware that dexamethasone is included in the majority of myeloma treatment regimens and has a high symptom burden. As a nurse working in myeloma for over 30 years, I can certainly say that patients do describe that steroids are probably the hardest drug to tolerate in of all the different drugs used in myeloma. We know from earlier phases of this piece of work where we explored the impact of steroids. We interviewed patients and carers and clinicians, and I could publish a whole book on quotes of patients describing how they feel when they take their dexamethasone. But we know there are a whole range of physical effects, but this study has probably been most useful in being able to provide some data and evidence to support the emotional and behavioural impacts of steroids in those with myeloma. Probably the practice-changing piece of work that was undertaken was the reporting of the SWOG study that explored lenalidomide with high-dose dexamethasone versus lenalidomide and low-dose dexamethasone upfront treatment for myeloma, and it was published in 2010 or 11 by Vincent Rajkumar and colleagues. And this study demonstrated that it was actually an increased mortality in the associated with high-dose dex due to toxicities and not least the infection and deaths caused by infection. And this caused a practice change pretty much overnight from the high-dose pulse dexamethasone we used to use of 40 milligrams 3 days in a row, 3 times within every cycle, down to a more reasonable 160 milligrams per cycle of dexamethasone. We also published a consensus paper on steroid-associated effects in about 2017, I think, and this in the Clinical Journal of Oncology Nursing turned out to be one of the most popular downloads of all the toxicity consensus statements that we reported at that time, again demonstrating what a significant problem clinicians have in managing patients on these drugs. So this piece of work was a 4-phase study. As I mentioned, we started exploring the experience with qualitative interviews and then identified an instrument that existed that we adapted that explored dexamethasone dosing as an antiemetic. We took that and further did some testing with patients, clinicians and carers to develop a steroid symptom questionnaire, which we pilot tested demonstrating feasibility. And now we have just completed a larger cohort test testing the validity and psychometric properties of this tool, which I'll show you now. The study design was a multi-centre cross-sectional study recruiting from 5 hospitals in New South Wales, Australia. Patients with myeloma taking steroids as part of their treatment were able to participate. We tested the tool in English only, so it was a requirement to have a good understanding of written English and a reasonable ECOG level. We delivered the Pro Tools in paper or e-copy and collected some clinical and demographic information, which I'll share with you. We used SPSS and REDCap as our data collection and analysis tool. The tool is the Steroid Symptom Questionnaire. As I mentioned, was developed over a number of years. It is a 20-item questionnaire, 19 symptoms and 1 question asking about elevated blood sugar levels, 4-point Likert scale, which is pretty standard for PROM tools. Overall higher score equals higher symptom burden. The tool was developed, can be used in research. It was developed as a clinical tool with clinical utility, so we also built into the tool the option to list other side effects people feel were related to their dexamethasone, and also to say which which symptoms were most bothersome. I mentioned that we've already demonstrated good feasibility and acceptability of this tool. Concurrent tools that we used in this portion of the study, which is critical to demonstrate psychometric properties, is that we used a standard quality of life questionnaire and the myeloma subdisease tool of that to do look at associations between the symptoms in the steroid tool and other myeloma tools. The patient group, we had 140 patients recruited, which is pretty representative of a myeloma population, average age nearly 70, good division of male and female, good amount of experience of myeloma, anything from 4 months to 22 years, and a reasonable number of prior lines. What is interesting in the clinical characteristics is I think this demonstrates quite nicely how the dose of steroids per week and per cycle is quite variable, and I think this just represents the fact that we dose reduce steroids very commonly in the real world, in the practice setting, so a range of 4 to 80 milligrams per week or 12 to 180 per cycle, I think is probably what we all see in our own practice. The symptom frequency and severity together equate to describe a symptom burden. I think you can see here, similar to the pilot testing we did with the tool, that there's a high frequency of symptoms reported. Most symptoms were actually reported at over 50% in patients, with disturbed sleep over 90% and fatigue and trouble concentrating even 75% reported, but also of the symptoms reported, a large proportion of them actually occurred at a severe level, which is why we know that the burden of these symptoms is quite high as it relates to steroids. Also, the number of individual symptoms experienced is high, 10.5 and 4.5 of those being severe symptoms. And don't forget, this is symptoms as they relate to just one drug, dexamethasone, and we know that the treatment of myeloma includes a range of different drugs that all have their own symptom profile, as you would be very familiar. This just demonstrates here the frequency and the severity of the symptoms, with all the symptoms listed here that exist in the steroid symptom questionnaire, not just physical symptoms, but emotional and behavioral. And you can see here resonates with me, difficulty concentrating and agitation reported in 60 or 70% of patients. And in terms of the severity level, disturbed sleep, of course, but difficulty concentrating, anger and irritability are also reported as severe in a large number of patients. We did explore, which is pretty standard, testing psychometrics in these tools, variables with other clinical and demographical data, and we explored the total symptom burden as it related to these other factors, and we were able to demonstrate that there were correlations with years since diagnosis. So the longer you've had the diagnosis, the higher the symptom score. Also a higher score in females versus males. It'd be interesting to explore what components of the symptoms that might align to, and higher ECOG is associated with higher score, which is not unsurprising. We also found, when we analysed the other tools, the quality of life tool and the steroid tool, that we found there was an association with higher steroid symptoms and lower quality of life. Not surprising. And we also found that higher steroid symptoms was adversely impacted social and role functioning as well. So the on effects of steroid toxicity is certainly demonstrated well. We did some factor analysis to look at the tool as a whole, and whilst it is principally a total symptom index by which you can add up the scores of all the symptoms to give you a total symptom burden, there were very clear subscales demonstrated using factor analysis. We haven't quite gone firm on the naming of these subscales yet, but there's certainly a psychological subscale, physical sensations, and this says physical functioning, also so a physical and a psychological subscale. And this is going to be particularly useful. These are the subscales I'm highlighting here, and some single items that didn't hang together in a subscale is going to be useful in research, particularly when we can explore a little more the impact of steroids in particular areas of people's quality of life, and apply some intervention work ahead to see if we can help improve situations. In terms of the psychometric tests, in summary, those are reported here and aligned to the principles of EORTC and problem development and validity. We were able to demonstrate that the steroid symptom questionnaire subscale scores did correlate with other measures of similar constructs in other tools, and that, for example, that means that the subscale of the psychological subscale in this tool correlated with the psychological subscale in the C30, and as an example of one item, the disturbed sleep correlates with the insomnia scale within the C30 as well. And again, just demonstrating good, strong validity of our tool. So in summary, I think I've demonstrated that the steroid symptom questionnaire is a patient-reported outcome tool that clearly measures symptoms and concerns for those people with myeloma on steroids, that we know we've got further evidence to demonstrate the significant symptom burden caused by steroids, and that this occurs across physical, emotional, and behavioral effects. Disturbed sleep is by far the most commonly reported in terms of frequency and severity, and we've been doing some work on further exploring the nature of disturbed sleep in this patient group, with the hope of undertaking an intervention study as well. We've clearly demonstrated the psychometric properties of this tool, and that there are subscales that will be useful to explore further in research studies ahead. It's principally developed as a clinical tool to help us manage our care of patients, but also already there are people interested in using the tool in clinical studies and trials to further build the knowledge that we have on the toxicity of steroids, and hopefully work towards steroid sparing regimens and dose reduction algorithms ahead. Next steps, the tool is going to be housed with the MAPI Research Trust. It's not quite available on there yet, but if you go back in a couple of months, you should find it. We're just sorting the scoring manual to go along with that. It's going to be freely available to clinicians and non-funded academics, and a charge to cover the costs for MAPI will be for those larger studies that are fully funded. We're going to be writing up the validation study in the special hematology edition of seminars in oncology coming out early next year, but we'd really like people to use the tool in their practice to help manage patients on dexamethasone with myeloma. Very, very happy to take any questions if anybody wants to email me or interested in using the tool ahead. And I just wanted to acknowledge the various other people, and of course the patients and carers that live their lives trying to manage all these side effects with steroids and everything else we throw at them. So thank you for your time. I hope that was useful, and I hope you have a very enjoyable educational event there in London. I think you're in London, are you? Anyway, bye from me. Come visit. I'm in Sydney. Lovely place. See you. Bye.